Thank you. Okay. So, thank you so much for a kind introduction there. Um I'll start my share screen. Yeah. Okay. Fine. Hope I'm visible and audible too. Any response, please?
You are audible.
Yes. Thank you. Okay. So, myself, all the way from Bangalore. First and foremost, thanks to KLE Institute and for their amazing job. I think they are all pro academics and pro profession. Amazing work they do, and I am always appreciate their work. Belgaum people, especially the KLE Institute, is doing wonderful job in serving the society as well as the serving and enriching physios in their professional knowledge and upliftment. Anyway, let's start the session. Um, I today actually wanted to expose our physios and reiterate that headache is the actual management by a physio too. Most of the time, in most of the departments, if we get a patient with headache, we would usually say, no, no, I think we'll have to refer. But I think we have got lots and lots to do when it comes to headache, and that is what where I am here to reiterate. Anyway, so let's get into uh, so headache, head pain, cephalalgia, call it any way you want, it haunts, isn't it? Headache is a headache to have, headache to diagnose, and headache to treat in a lighter sense, isn't it? So, everyone on this earth would experience headache at least once in a lifetime. If you're married, every day, in a lighter sense. Anyway, from a small child, uh, a small girl to a beautiful lady to a old lady, headache haunts. Nobody is spared. So, uh, one of the commonest problems seen in healthcare industry is headache, causing much pain and disability, and it can lead to depression and frustration, and it can affect the person financially, spiritually, and whatnot, emotionally, and financially, very importantly. So they are socially away, and headache actually haunts. In fact, whether it is acute or chronic headache, definitely, we all know that it's really debilitating and difficult to cope up with. And there has been numerous treatment approaches to manage headache. Commonest being, medicines and physiotherapy, cognitive behavioral therapy, and yoga, of which the European Federation of Neurological Societies have apparently concluded that non-drug management, physiotherapy and needling must be considered. And manual therapies are the therapeutic strategy. In fact, most requested by patients with the tension type headache. Actually, also to mention, a national study conducted in USA revealed that most individuals with headache, sought alternative therapies and, in fact, manual therapy. So now, International Classification of Headache Disorders, the third edition, with it classifies there are more than 150 different types of headaches. So, and of course, it's got two main categories, the primary and the secondary. With so many different types of headaches, I think it is definitely an enigma, it by itself, even to understand it, to treat it. And that's the classification: primary headaches, secondary headaches, neuralgias, and other headaches classified by ICHD. Anyways, let's not get into much details of classification, subtypes, incidents, prevalence for now. Question is, are all headaches diagnosed or in the lines of ICHD guidelines? Maybe, may not be. Okay, now another question. A person with headache should approach whom? It's a big question. ENT surgeon, neurologist, physician, ophthalmologist, psychiatrist, or ortho, neurosurgeon, a dentist. Even the list goes on, to Ayurveda, homeopathy, naturopathy, rastropathy. Sorry. So then why not a physio is a question. Why not a physio is a question today. If a patient walks into your department or a clinic with headache, how many of us actually treat it? That's a big question. We say it's not my headache to treat your headache. See a neurologist or a physician, isn't it? We should realize that headache is our cup of tea too. Even if it is purely mechanical headache, we many a times wrongly, cross refer to a chemical management. So though you can actually manage that headache mechanically. So, do we commonly see a person saying, a person or a patient saying, I've got headache, let me see a physio? I think that should happen. That's my contention today. How many of us are confident to treat headache? Yes. The contention here is a physiotherapist also should be a primary assessor, primary caregiver, a primary contact for all headache sufferers. That's what is my. We don't consider headache as our domain. That's the sad part of it. Please underline my contention here. Physio should be a primary contact, come what may. We are first when it comes to pain management. Why not headache management? Yeah. All right. So headache is known to have primary or secondary cause. Also, they have primary or secondary manifestations or the symptoms. So clinical features. So it is imperative to treat both clinical manifestations. So if primary cause happens to be mechanical means it has to be myofascial or articular dysfunction, then physio's intervention can substantially treat the chronic headache forever. Let's not limit ourselves up to the neck. You see, let's rise above the neck and treat head also, so called the head pain. So if secondary myofascial or articular involvement is found, then our intervention as physios can give, if not fully, at least partial solace, definitely, or pain reduction, which itself will be a boon for the headache sufferers or subjects having chronic headache and then been suffering from a long time or many years. So our management is such cases can be actually a parallel intervention. So it can be a parallel intervention to chemical management, something like which happens in rheumatoid arthritis. So physical therapy runs parallelly to chemical management. So if it is purely mechanical headache, we can definitely take care of it. And if there is chemical management required, there is definitely mechanical side of every headache. So a physio has a major role in a headache management, contrary to what was thought, as I mentioned earlier. It is a new dimension of intervention that we can actually get into, and we have comprehensive therapies that we can offer to treat headache. Either treat the source or treat symptomatically. That should be our motto. So whether acute or chronic headache, we definitely can treat the symptoms or the cause. So trigger point is our cup of tea. We all agree. We love treating trigger points. Yeah. Today that has become our practice base. when it comes to pain management, all that. So, and we all are big fans of travel and Siemens, isn't it? So they have found in a study that there are 54.6% of headaches and neck pain are caused by trigger points, be it tension headache, temporal arthritis, or cluster headache, whiplash, name it. Subject experiencing the headache may have pain around the ear, occipital area, or even the scalp, or the jaw area, neck area, eye area. They say the pain around the eye. Trigger points in muscles may have referred pain also. So the referred pain can move down, move up, to jaw, scalp, different areas. A chronic headache may even lead to emotional disturbances. Stress may predispose or further worsen the symptoms. And sleep is another thing. Lack of sleep is also a contributing factor for headache. So the clinical, as the picture shows, clinical myofascial and articular manifestation of headache may reflect in the scalp and a few other places where, superior nuchal line, suboccipital muscles, especially OCI. I have to have a special mention on OCI, is obliquus capitis inferior, and upper trapezius, vertical fibers, and the horizontal fibers, and the splenius capitis at its attachment, then the sternocleidomastoid, the scalenes. The scalene is missed out in the picture. Anyway, scalenes, and then corrugator supercilii. I have a paper to show later how important is corrugator supercilii when it comes to migraine type of headache. I'm going to show that. And the trigger points in masseter, temporalis, occipitalis, the whole Galea aponeurotica, and of course not to miss the TMJ, temporomandibular joint dysfunctions that we treat, TMJ, or even the C2 vertebra dysfunction, etc., can all cause. So all these structures actually can cause tenderness, dysfunction, or the trigger point. Of course, uh, these things which we handle very well. So most of the headaches have either primary or secondary involvement of myofascia. You can have a misaligned vertebra, which can, the problem is in articulation, and then that can bring spasm in the muscles, and then that can irritate the nerve, and then that can tighten the muscles further, and then it's a vicious cycle which goes on. So taking the advantage of the biomechanical assessment and interventional skills that we as physios possess, so we have a huge role in headache management. So we can always break the vicious cycle, and then to an extent definitely alleviate headache symptoms. So there are many common symptoms and what is called as strange symptoms we usually see when it comes to headache. Common symptoms are like deep ache or band-like pressure, sharp throbbing pain, and then the headache can be with aura, without aura. We all know that. Anyway, what I want to specially mention is the strange symptoms. There are various strange symptoms that they get: headache, um, presenting with referred pain or a toothache. They think it's the tooth which is causing the headache, or a headache can be associated with vertigo or dizziness, nausea, or sinus involvement, and tinnitus. So many a times, toothache has led to the subject to a dentist thinking, oh, headache is caused by that. Headache has resulted in unnecessary tooth extraction. Tinnitus has got ENT surgeon to see them. We have seen patients with headache and hard of hearing. So we in our department have seen a lot of patients hard of hearing, blurred vision, and tinnitus in the ear. And after we intervened, after we managed headache, the symptoms disappeared. Their vision improved, their hearing improved, tinnitus disappeared for our disbelief. So we've got a lot of experiences like this treating headache. Once you treat headache, these strange symptoms, most of them we have taken out. Patients would have gone everywhere. They would have seen n number of doctors without much this thing. When we have intervened and treated, headache is gone and the strange symptoms have gone. And we have seen TMJ or even tooth pain disappearing after mechanical headache management. So, what to infer with all this? I think we as physios can do a lot, is what I think we should read from this. Anyway, so what is important? Assessment is the key, of course. So, identifying the biomechanical fault and reading the pathomechanics well, very well, read the pathomechanics is the key, and to assess the structures involved is very, very important. So very importantly, more than the assessment, I also want to mention some red flags. So I'm sure most of you will try now. But before that, keep in mind that red flags are very, very important to be checked for. Red flags come in the mnemonic of SNOOP, SSNOOPPPP, and they represent, systemic symptoms. You can very well know with the history of the patient whether there was fever, so which caused headache, or chills, or weight loss, or the secondary risk factors, HIV, cancer, head and neck trauma, or in acute headaches. Then neurological signs or symptoms which you should watch for. Yeah, of course, we do watch for all that. Anyway, onset, whether there is sudden, abrupt, or a thunderclap, or progressive over long time, or older subjects, you will have to be a little bit careful. I'm not discouraging, but above 50 years, just be a little careful. I mean, find out, take good history, and then treat. Very well we can treat, whether it is 50, 60, 70 years, 80 years headache, 80-year-old headache, we can always treat. And of course, inflammatory markers have to be tested. The CRPS or can always be tested if you find in a little older subjects. And then, of course, positional headaches, whether it's worsening with sitting, standing, lying. When is the headache more, morning or evening? Whether stress induced, emotionally ridden, or activity induced, or they also have neck pain, you can always ask. And anyway, provoked activity, provoked, and migraine can be associated with aura also. And anyway, papilledema, and then previous history of increasing frequency, severity, all that has to be, taken care. And now I just want to quickly show you people the assessment practicals. So for the trigger points, so I have a video. Instead of me demonstrating live, I was suggested that I make a video of the assessment and then put forth, because net issues should not come later. So I'm going to put a video now. And before that, before I show you the assessment part, a quick assessment part, we also have to check for TMJ. Okay. So anyway, quick assessment. So most of the time, as soon as the patient enters, we know as physios, we biomechanical assessment would have already started in our subconscious mind. So we would observe their stoop posture, or thoracic kyphosis, or rounded shoulder, and poking chin. All that we would have already observed. So that is in our what do you call, so subconscious mind. So once we start the assessment, so once the chief complaint is noted down and the assessment part is starts, so I'll show you the quick screening. So first thing is the posture, whether there is a rounded shoulder, whether there is kyphotic posture, or there is a poke chin, or a carrying angle. Both are different, you see. A carrying angle or poke chin has to be checked for. That is about the posture.
Sir, sorry to interrupt you. You are not visible to the participants.
I am not, sorry, wait. I am not visible, is it?
Yes.
No, that's okay. If the video is visible, that should be enough.
Video also is not available. You have not shared the video on the screen, sir. We are
Oh,
also
is it
not able.
so?
Yes, we are also not able to see.
Now, is the video shared?
No, no.
Not yet. Oh, okay. So how do I share that? Okay. You are able to see my screen now?
Yeah, we are able to see you. Yes.
Okay. Now I think I'll. Now is the video seen?
No.
Okay. So I'll have to go there and then share screen. Sorry for this. Now?
Yes. Yes.
Now just check whether the audio of video is audible.
Yes. So video is also available. You can talk.
No, audio is not audible with the video.
Yeah, audio of the video is not audible.
Oh, okay. Then I'll explain it. All right. So anyway, I'll explain. So I'll just explain a quick assessment, not to take much time of you people. So as soon as the patient enters our department, so subconsciously we as physios, assessment starts going on in our subconscious mind. Our biomechanical assessment starts as soon as we start seeing the patient.
So we are able to hear. We are able to hear your audio in the video.
Oh, is it so? Okay.
Yes, yes.
All that we would have already observed subconsciously. That is our involvement as physios. And once the patient has come and said they have a headache and have given chief complaints, and you have noted down, you have documented. Now the assessment part, quickly screen, or as I said, the rounded shoulder. I'm observing whether there is rounded shoulder, whether it should be sitting here. Then the poking chin and the carrying angle. Carrying angle and the poking chin, both I observe, and then see at what angle it is deviated and then correct it later. Then the muscles to be screened quickly are for trigger points are the trapezius, upper trapezius, horizontal fibers, upper trapezius, vertical fibers. So I check for trigger point. Then with the opposite and thumb, I check whether there is any trigger point in the vertical fibers of upper trapezius. And then quickly move my fingers little and laterally to see whether there are any trigger points on scalenes, the anterior, mid, and the posterior scalenes. And then I move little more anteriorly to hold on to SCM. That's the sternocleidomastoid. I check for trigger points there, and then move little up to the mastoid process to see whether there is any trigger point at its attachment. And then slowly I move along the supranuchal line or the suboccipital line just to see whether there is any trigger point around there, especially where splenius capitis attaches or vertical fibers of upper trapezius attaches. So I quickly screen for this, and then the mastoid process. And of course, I go in front and then check in front of the tragus and on temporomandibular joint whether there is any trigger point or any dysfunction of the temporomandibular joint. I place my digit there and then may ask the patient to open the mouth and close the mouth and then feel for the click and the tenderness, and then from front assessment I see whether there is any deviation of the mouth when opening. So that is temporomandibular joint assessment. Then also I check for masseter trigger point, so which influences the TMJ, and of course medial pterygoid. and mainly the temporalis muscle, which is also a key contributing muscle for headache, and then the corrugator supercilii. Corrugator supercilii, the frowning muscle, also check for its trigger point, whether there is any trigger point. Then of course I run my digit, palpating or trying to find the trigger point over the area neurotica, which connects from occidentalis to frontalis. Then also over the scalp above the ear for trigger points. Sometimes we find trigger points in this area which you can treat. Then, of course, not to forget the C2, the first spinous process that we can palpate in the cervical area is C2. So, thumb over thumb, I go on that and palpate or slight pressure to see whether it is tender. If it is tender, then immediate measures, there only I can try to fix C2. Is some of the assessment for key structures, key trigger points that we'll have to do. Okay. All right. So I come back and let me show the slides there. Yeah. So we saw the little assessment part. So how we can actually screen. So in detail, you can screen in your department, and not to miss any of those key structures that I have mentioned, and then appropriate intervention can be done. So. Why isn't it moving? Screen is seen.
Yes, it can be seen.
Yeah, thank you. All right. So now the question is how to, what to, and when to choose. Yeah. So we've got so many interventions as physio. We have dry needling, invasive technique to non-invasive techniques, and of course, manual therapy today is one of the techniques that's extensively used in pain management, and trigger point release therapy, and then deep tissue. So I call this as the weapons of a physio that we have in our hands to treat headache or the pain management. So interventions as physios, I call this weapons of headache destruction. Manual therapy today find its place on top of the treatment chart, from silencing a trigger point, to aligning the articulations to motor control. And to mention few, of course, the manual therapy techniques we all know: trigger point release to deep tissue to soft tissue to active release to PNF techniques and integrated neuromuscular inhibition technique (INAT) to Mulligan, Maitland, Kaltenborn traction techniques, manual traction technique that we can offer to the cervical spine, and the joint glides and etc. And of course, dry needling with the research evidences, in fact, going for it and against, has shown to be extremely beneficial, at least in our practice. So I would call, whether it is practice based or clinically based evidence, it is for us. Practice based evidence is actually for dry needling. We are getting good results. So when trigger points are stubborn or adamant, of course, we can, dry needling can be very handy. Therapeutic exercise has been our bread and butter, and of course, it has a high uh, quality management in headache. And posture correction has a high influence, and electrotherapy has been, favorite and continues to be favorite basic physio tool in many departments. And posture, of course, one thing I have to mention, more than rounded shoulder, poking chin, it is the excessive thoracic kyphosis. So we will have to work on the thoracic extension, which is the cause for the poking chin or head carrying head angle. So once that happens, everything else. So once you straighten the thoracic spine extension is very, very important, is what I wanted to reiterate. So usually in the first sitting, I would actually employ, after the assessment, of course, detailed assessment, history, chief complaints, all that done. And then when it comes to management, the first sitting, usually I employ manual therapy. Depending, it's a tailor-made, depending on the patient's requirement. So what you want to use, you can use, but what is required are to treat the trigger point effectively or treat the dysfunction effectively, whether it is TMJ causing or C2 dysfunction or the trigger points causing what may. Along with that, of course, complementary electrotherapy can be employed. And in second sitting, usually I call them after 3 days, and then I repeat the manual therapy, whichever required. And then, of course, TMJ manipulation, we employ TMJ manipulation, intraoral manipulation, mobilization, and then we also teach them Rocabado exercises if temporomandibular joint dysfunction is detected. And then I, of course, employ dry needling. So this is a small another video of 2 minutes, dry needling. If you permit me, I can share that.
Yes, sir.
How do I go to my desktop from here?
So you can minimize it, go back to your desktop.
Oh, minimize
your screen share. Just end the show, go to the end show, go to the
oh, 1 second. I switch on share, is it?
You end your share screen, sir.
Okay, fine.
Yeah. Go back to your video. You end your share screen, go back to your video, and then share screen again.
So I've already stopped share. Okay, I've stopped.
Yeah.
Now again I go to share screen, is it? Minimize,
No. Go to your video, sir. Go to the video and then share screen.
Sorry about this. Yeah. So I go there. No. This one. Not going. This is not going at all. No, I have little, I'm little this thing with these things. Anyway, if somebody can help me, how do I go to desktop and share the screen? This
so
way?
You
Press share here. Huh?
Yes. Yes.
No, but that's not my video. Anyway. This is there.
Go to stop share first, sir. Stop share screen first. Then go to your video, again share the screen. You muted yourself. You muted yourself. Please unmute yourself. So unmute, yeah. Yes.
Yeah, I've done that. Now you can see my screen, no?
Yeah, we can see you on the screen now.
Oh, okay. Yeah. Okay. Now I'll show you the video. Is the video seen?
No.
Is the video seen?
No, sir. You have to share it.
Okay. Share. Huh? This one. Oh, all right. Yeah.
Yes. Yes. Now we are able to see.
Yeah.
A little bit about dry needling practicals. So, key trigger points we have identified, which are classified. Trigger point has to be needled. Needling has been a physio's of late favorite tool. A little invasive technique that physio has lectured, but has a very good benefit when there is adamant or non-dissolving trigger point for manual therapy. Then we go for needling. We get various types of needles. This is 100 mm length in length. This is 75 mm in length, 60 mm in length. This is 50 mm in length, 40 mm in length, 25 mm in length, 13 mm length also we get. A smaller length needle is used mainly for subcutaneous muscles like corrugator supercilii, frontalis can be needled with.
Sir, sorry to interrupt. You have 5 more minutes to go.
Yeah. I'm going to.
The trigger point, thickness of the muscle, the needle sizes vary. Firstly, a gloved hand, a well sanitized gloved hand. Keep a cotton again with the sanitizer in it, soap, and then we take the needle, the required size needle, and then open it up, bend this down, and you expose the inner needle. Once exposed, that's the safety
Lock.
you remove and hold the needle at the junction of the guide tube and the needle. Hold it this way and go place it on the.
So how do I change the stop? Remove. Yeah.
Stop sharing and go to your PPT again.
Yeah. Is this playing now? No. Okay. So I put screen sharing.
The point on the trapezius horizontal fibers, upper trapezius horizontal fibers. All we have to do is place it on the key trigger point, tap it. As you tap it, in one hand, one action, place the guide tube between your fingers. It will stay there. If you want to reuse the needle, this will be useful. Then all you have to do is, at the junction of the needle and the handle, all you have to do is go ahead and needle the trigger point. You may get local twitch response, and then that will be the sign of the right point to needle. Sometimes you don't get LTRs, but it's okay. Then if you can twiddle it and then do it, the fascia, if it is adhered, will also release them. So I am twiddling it, twiddle the needle and then do it again, and then take it out. And then if you want to needle again, I am holding the junction again there. Put it inside from backwards, block here, leave it to fall down, then again retract it a little bit back, hold it at the junction, the needle is ready to be reused. So let me show the suboccipital needling and identify the supranuchal line trigger point. Supposing I find a trigger point there, all I do is place my fingers, just above and below the trigger point. Place it on the trigger point and then slightly tap, and then the guide tube goes between the fingers in one single hand, one single motion. Then you can needle this, you can twirl it and then take it out. So same way the corrugator supercilii muscle, same way the corrugator supercilii muscle also can be needled, and OCA, especially obliquus capitis inferior, can be needled and has very good benefit with the needling. Thank you so much.
So these are the practicals. Wait. Yes. I can minimize this. Yeah. This will go there. Yeah. Sorry about a little bit glitch. That is how we are, when it comes to technicality, we are a little slow. But when it comes to professionalism, no letting, no beating us. Anyway, third sitting, after yet another 3 days, I would always review the patient, then appropriate previous intervention, be it manual therapy, whatever. Then we also next step is to teach self-release techniques like digital pressure, digital release, chair head can be used, or the bed edge can be used, and of course deep neck flexors have to be activated, teaching the nodding. Longus colli and longus capitis are very, very important muscles to reduce the poking chin. And cervical spine lordosis building exercises also very important, and then sustained neck muscle stretching also very important. More emphasis on thoracic spine extension, as I said. Next slide. Okay, here it is. Interestingly, there is a study on corrugator supercilii, where Gairan B et al. In 2000 did a study on correlation of corrugator supercilii muscle in 314 migraine headache patients. They resected the muscle, and for their disbelief, they saw significant improvement or elimination of migraine headache. So as physios, why get it resected? Not surgery, but if you find corrugator supercilii being the main cause, or you find the trigger point in your assessment, all you have to do is manual therapy, deep tissue, not listening, needle. So we have good weapons to treat corrugator supercilii trigger point. Also, needling OCI, obliquus capitis inferior, has shown substantial reduction in headache. So we do a lot of OCI needling when it comes to headache. So thus, a physio's role in headache management is quite comprehensive. Hope everybody agrees with this, and is a parallel intervention to medical management. And in some it is parallel management, and it is sole intervention if it is mechanical. So in some headaches you'll have to treat, you can treat yourself. Some headaches needs medical management also. So there is a need for increase in awareness among sufferers as well as other medical professionals on the potential of a physio in managing headache, as well as awareness in physios also that we can treat it very well. And a physio should have a first contact practice to assess, treat, cross-refer a subject suffering with headache. What say? Thank you, folks. Anyway, thanks for the opportunity given to me to showcase my experience in treating headache. Thanks to KLE again.
Thank you so much, sir, for that wonderful insight on headaches.
Yes.
I guess diagnosing and treating headache itself is a headache for the neurologist, the physiotherapist, and needless to say, the psychiatrist as well. On a lighter note, I just had one question to you, sir. What is the role of electroacupuncture in treating headaches? Have you ever treated any patients with electroacupuncture?
We try electroacupuncture can be tried, but as such electroacupuncture is not being researched well. So when you name it acupuncture, and then I'm not for it, because acupuncture has its own method of treatment, like a meridian system. There's a liver, there's a kidney, there's a brain here, and then you needle there, and then so we are not, as physios, we are not going into those meridian system, and for us it's absurd. And then we have our own scientific based needling techniques, where we take mechanical advantage, vascular advantage, neural advantage. So overall physiological advantage we take with a needle. So where we treat the actual trigger point, the key trigger point which we treat, or sometimes latent trigger point, to prevent predisposing of headaches. So you call it needling, I'm with you. You call it acupuncture, it becomes a different domain, and meridian system and all that, which we can't digest that. So anyway, needling, if needling can help, you add a little stimulation to it, can help some of the trigger points, being treated. But most of the time, you needle it, one sitting or two sitting needle, the headache is gone, or the trigger point itself is gone, basically. So adding a electro, you can add if you want to.
Thank you so much, sir.